Hey everyone, it's Sarah with registerednursern.com, and in this video I'm going to be doing an NCLEX review over Crohn's disease. Now in the next video I'm going to be doing a side-by-side comparison of Crohn's disease versus ulcerative colitis, so be sure to check out that video. And as always, in the YouTube description below or at the end of this YouTube video, you can access the free review quiz that will test you on Crohn's. So let's get started. First, let's start out talking about what is Crohn's disease. Crohn's disease is a type of inflammatory bowel disease that causes massive inflammation and ulcer formation in the GI tract. Now, another type of inflammatory bowel disease is ulcerative colitis, and we talked about that in the previous video. So be sure to check out that lecture when you're done with this one. Now, let's talk about some key points that you need to remember about Crohn's so you can understand the nursing interventions, the signs and symptoms, and all that goes together. Okay, first, Crohn's disease can be found in both the large and small intestine. So let's go back and review our anatomy. Because whenever we talk about ulcerative colitis, it is found specifically in the large intestine. Crohn's can be anywhere, from really the mouth to the anus. So let's go over our GI anatomy. Okay, we have our stomach. Then it connects to our small intestine starting at the duodenum, which is the first part. Then it goes and you have the jejunum, and then you have the last part of the small intestine called the ileum. And then the ileum enters into your large intestine at the cecum. And then right below the cecum, you have your little appendix, and you have your large intestine is divided up into some colon segments. You have your ascending colon, which goes up. You have your transverse, which goes down. You have your descending colon, then you have your sigmoid, which makes a little S, into the rectum, and then you have the anus. Now, with Crohn's disease, the disease is most likely to be found in the terminal of the ileum and the start of the colon. So most people who have Crohn's, it's more likely going to be at the end of the ileum, the terminal part of it, to the beginning of the colon. And Crohn's disease affects all the layers of the bowel. In ulcerative colitis, it just affected the inner lining, like the mucosa and the submucosa. But with Crohn's, it will affect everything all the way to the serosa. And that is why you see different complications in Crohn's disease compared to ulcerative colitis. And we'll go over those a little bit later because it's affecting that whole bowel wall. Now, what's really interesting about Crohn's is this disease is found in scattered patches throughout the GI tract. So you may have some healthy lining, and then next to it you have this disease lining, and then it'll skip again, have healthy, and then disease. And whenever a patient is scoped, which is one of the ways they can diagnose this, they go in with a camera and they look in that lining, it will have this like cobblestone appearance to it from where you're seeing the ulceration and the healthy lining. Now, with ulcerative colitis, what was really interesting about that is that it starts in the rectum and it just migrates all the way up through that large intestine, depending on the type of ulcerative colitis they had. And it goes in a continuous fashion. It doesn't have the skipping like with Crohn's, because with Crohn's, you can have some here in your ileum and then maybe a little bit in the colon, and it can be in random areas. So that's what makes it different. Now, the causes of Crohn's, it's not totally known. They're still doing research on it, but they know that it's due to a faulty immune system. The immune system isn't doing the right job. It's causing an inflammatory response throughout the body and causing your intestines to be so inflamed that it messes up that whole bowel wall. But they think it can be triggered by certain things in the environment, like the person's food, dairy products, or stress, or a viral or bacterial illness, smoking, things like that. And it tends to run in families, so it tends to be genetic. Now with Crohn's, you will have periods of flare-ups and remission where they don't have any signs and symptoms, but this is an ugly cycle because they'll have the inflammation, which will heal. What happens when you get an injury and it heals? Scar tissue forms. So that's where a lot of our complications are going to be coming from because of these flare-ups, and remission because the tissue is going to become really scarred, which can lead to a stricture, which can lead to an obstruction, which is one of our complications because this disease is affecting that whole layer of that bowel. Now, there is no cure for Crohn's. Like within ulcerative colitis, they can go and have that large intestine removed. They'll get a permanent ileostomy place where they'll be able to release the stool, or maybe J-pouch surgery, which can help them with that. But with Crohn's, they can't do that because why? Crohn's can be scattered throughout. So if you have some here in the ileum and the colon, we can't go and just remove all of our intestines because we need those to survive. So one thing they can do is like a bowel resection where they can go and maybe remove part of this disease part of the bowel that's diseased and then reconnect it with the healthy, so you got rid of the disease part. And it can be managed with medications and diet, which we're going to go over a little bit later in this lecture whenever we talk about nursing interventions. Now let's look at our types of Crohn's disease. Just like with ulcerative colitis, we talked about the types, and the types depend on where the Crohn's is actually located because, like I said, it can be throughout the GI tract. So let's go over these real fast. Okay, you can have what's called ileocolitis, and this is inflammation found in the ileum and the colon. So looking back at our anatomy, in this area and in the colon. Then you can have gastroduodenal Crohn's, which is found in parts of the stomach and the duodenum. You can also have jejunoileitis, which is found in the jejunum. And you have ileitis, which is found in the ileum. And you can have granulomatomus colitis, which is found only in the colon. Now let's look at the complications associated with Crohn's disease. Now with Crohn's disease, you're going to see some unique complications when you compare it with the other type of inflammatory bowel disease like ulcerative colitis, just because of the way that Crohn's disease affects that integrity of the bowel lining. So for testing purposes, whenever you're studying for your nursing lecture exams, pay attention to these complications whenever you compare them with ulcerative colitis, because a lot of times scenarios like to ask you which of the complications is with Crohn's disease, and you have to select them all. So to help you remember the complications, because there's a couple of them, remember this mnemonic. Abscessing fistulas may form sepsis, and this mnemonic helps you remember a couple things. It helps, each letter will refer to the complication, but it reminds you that with Crohn's, we're going to have issues with abscesses, fistulas, which can lead to sepsis. And sepsis is where the patient has infection, it can lead to death. So let's go over the first one. Okay, A for abscess. What is this? This is a pocket of infection that forms within the intestine wall. And these abscesses can burst. And whenever they burst, they can form fistulas. Specifically, anal abscesses can turn into fistulas. And this is one of the problems that people with Crohn's disease can have. F for fistula, this is where an ulcer or an abscess has formed deep in that intestine wall. And it creates like this channel or passage either from the intestine to another intestine, or intestine to an organ, or an intestine to the skin surface. And this is not good. It's not, you're not made to have a fistula. And what can happen is, for instance, let's say it's connected from the intestine to an organ. Let's say it's the bladder. The bladder is a sterile organ. It does not like germs. And anytime you get germs in the kidneys, it can cause renal failure and cause a whole slew of problems. So because whenever you have the intestine connected to the bladder, it's just draining back and forth or mixing together all the bacteria from the intestine that's not meant to be in the bladder, and it can lead to sepsis. Now there's various types of fistulas, and I'll go over them with you. Your medical terminology will help you learn which one they are. We have what's called an introenteric, which is where you have an intestine connected with another intestine. perianal, around the anus area, and this is due to one of those abscesses bursting. That's normally what causes that. An intravesical, which is the intestine connected to the bladder. Then you have the intravaginal, which is the intestine connected to the vagina. And then you have the intracutaneous, which is the intestine connected to the skin surface. Now let's look at another complication. M for malnourishment. Patients with Crohn's are definitely at risk for malnourishment issues. Why? Okay, let's think back to the little bit at the beginning of the lecture. The main area that Crohn's disease is going to affect is that small intestine. And the physiology, what does the small intestine normally do? Small intestine is responsible for absorbing most of our body's nutrients. So if it's inflamed, it can't do its job. Those cells are damaged, so those cells aren't really interested in absorbing that food that's flowing through there because they're inflamed and they're not working properly. So we're not going to absorb the nutrients we need. So you're going to see malnourishment most commonly in Crohn's, then ulcerative colitis. Why really not an ulcerative colitis? Because remember, the problem was with the large intestine. That's where it's mainly at. And what does our large intestine do? It really absorbs water. Because it went through the small intestine, got all the nutrients, and its role is to absorb water. So they can have some weight loss and issues, but mainly your malnourishment issues are going to be patients with Crohn's disease. F or fissure, these are tears in the lining of the GI lining or mainly in the anus, and this is where you're going to see these anal fissures, and these can bleed, these can be painful. Next is called a stricture, and strictures are very common in patients who have Crohn's. If a person has Crohn's, most likely sometime with their battle through Crohn's, they'll probably have to have surgery to correct a stricture. And a stricture is where you have major narrowing of the intestinal wall due to chronic inflammation. So remember, your intestinal wall does not like inflammation, and we have these periods of flare-ups with healing, flare-ups and healing. And what is that doing to the integrity of the bowel wall? It's causing scar tissue to form. So instead of being nice and open like this, that inflammation, that scarring is going to narrow it, very narrow. Now, what causes a big problem with that is that you have food or GI contents flowing through your intestines, and we want to flow nice and evenly. But if we have a narrow part, say we got some food in there that doesn't digest very easily, like foods like corn or something like that, gets in there, causes that blockage, and nothing can flow through. And it has to come out some way. So what will happen is they'll start backing up, and your patient, I've had patients do this from a bowel obstruction, they start throwing up what looks like feces because the food's there, it can't stay there, the body knows it can't stay there, they have to get it out. So they can have a bowel obstruction and have to go for strictureplasty, get it corrected. Now another thing that patients can develop, I threw this under the miscellaneous part, they can also with Crohn's, chronic Crohn's, they'll start to have problems with their joints like arthritis, stones in their gallbladder, skin rashes, and eye issues, because Crohn's not only affects your GI system, but it'll affect your liver and your gallbladder, just of how everything is messed up and how it's processing the acids and the enzymes in your body. So it starts to affect everything. Now let's look at the signs and symptoms of Crohn's disease. As a nurse, what are you going to see in your patients? What's the most common signs and symptoms? Abdominal pain. It's going to be very painful for the patient, and this is due to the inflammation in the gut causing them pain. It hurts, and it can be due to possible stenosing of the intestines or a stricture, so you want to watch out for that. And patients tend to complain of it in the right lower side of the abdomen. And why? Well, remember we said that Crohn's, a lot of patients have it in the terminal ileum. So that is down in the right lower part of your abdomen. So it'd be about right there. So that's why they're complaining of abdominal pain there, because that's where most of the disease is at and the massive inflammation is located. Ulcers, they will have them in their mouth. Some patients have them there or in the GI tract. Diarrhea. The diarrhea, they'll have frequent bouts of it. It can contain blood, mucus, or pus. And ulcerative colitis is more likely to have blood in the stool, but patients with Crohn's can. Also, they're going to have the weight loss, the malnourishment, electrolyte issues, because again, your small intestine plays a huge role in absorbing that nutrients, and theirs is inflamed and not doing its job. So they're going to be really suffering from that. A fissure, little tears in the lining or really around the anal area in patients with Crohn's, and they will bleed. Sometimes patients will think that they have a bleeding hemorrhoid because it's causing them pain and they think it's that, but in reality it is a fissure, and what's happened is because the integrity of the skin has broke, it's tore open, and plus why they have them anally is because they're having those frequent bouts of diarrhea and all that gastric and that acid is just coming out, coming over that fissure, causing them pain, causing them issues, and breaking down the integrity of the lining even more. So it tears. Also, they can have bloating in the abdomen from the inflammation. Now let's look at the nursing interventions. What are you going to be doing for this patient as the nurse? Well, our goal is to help the patient understand what is going on and understand about this disease. Because remember, there's no cure. So they're going to have this chronically, and they need to know how to manage it with diet, medications they may be prescribed, and possible surgeries. Some of them, like a strictureplasty, where they go in and fix that stricture, which can cause a bowel obstruction. Bowel resection, where they go in and remove the diseased part of the bowel and connect healthy with healthy. Or the patient may have a partial or total removal of the colon, depending on what type of Crohn's disease they have. And if they have that, the colon removed completely, they'll have what's called an ileostomy. And you'll have to be providing care to their stoma and educating them on how to do that. And I have a whole NCLEX review on colostomies versus ileostomy if you want to check that out, and a card should be popping up so you can access that. And other things you want to be doing is teaching your patient about quitting smoking, smoking cessation, because smoking makes Crohn's disease worse. It makes the inflammation worse. Patients who have severe cases of Crohn's disease, the physician may order complete bowel rest where nothing enters into the GI tract. Instead, they may be prescribed what's called total parenteral nutrition, which is called TPN. And as a nurse, you'll be responsible for hanging the bag of that. And what it is it will enter in through the bloodstream, usually through a central line. And the patient will get their nutrients that they need with that. But the patient is at risk for imbalanced nutrition still. So as the nurse, you want to make sure that they're getting good enough nutrition by monitoring their weights. Are they losing weight? Are they gaining weight? How's their skin integrity? How's their electrolytes? How are they doing overall? And you want to be monitoring that. Also, if they're not on that, if your patient does have Crohn's or not on bowel rest, you'll be wanting to monitor their intake and output, making sure that they're doing good with that. And GI assessment, really focusing on this during your assessment. You'll want to be asking them about their bowel movements. How many bowel movements are you having? You'll want to actually look at it. What does it look like? Is there a lot of blood? Are they having a hemorrhage? What's going on? You want to look at that. And you want to make sure that they're actually going. And you'll want to make sure that they have bowel sounds present. Are they hyper or hypoactive? You'll want to be palpating on the abdomen. Is it tender? Is it bloated? And you'll want to make sure that there's no bowel obstructions. Is your patient throwing up? And if they are throwing up, does it look like fecal matter that they're throwing up? Because that could be a bowel obstruction, anything like that. So you want to make sure you're really focusing on the GI system. And diet teaching. Okay, the key with the diet is these patients, remember, can have flare-ups and remission. And they'll want to avoid some foods that can cause a flare-up, or avoid some foods during a flare-up. And these include high fiber foods. And these are foods like your raw vegetables and fruits, a lot of fiber in those. And really, whenever you're looking at these test options on a test, and because exams for nursing love to throw out what can the patient eat, what can the patient not eat, because we are going to be providing care to that patient and we're going to be with them whenever they're having their food. So we need to know that. So think of something that is really, really hard on the digestive system to digest, because we want it to be easy for the digestive system to digest food. So of course, raw fruits and vegetables would be hard. Spicy foods, that's not good on inflammation. Fatty foods, not good, because we can't digest those and we'll have issues with that. Any foods that they're normally allergic to, like your wheat, your gluten, fishes, things like that that already bug them before, can cause even more problems. And anything that's really hard to digest, like the nuts or popcorn, things like that. Instead, they'll want to consume foods that are low in fiber, like white rice, or they can have fruits or vegetables that are cooked and the skins are removed, because that's broken down that fiber and it's easier on the digestive system to digest. So try to look at foods that would be easy for them. And foods that are high in protein, just to really promote some healing of that damaged tissue that they have. Now let's look at the medications prescribed by the physician in Crohn's disease. As a nurse, you want to be familiar with the different types of drugs. And medications are ordered by the physician depending on the severity of the disease. So if they have a mild case, they'll probably just be prescribed an aminosalicylate or corticosteroid. But if it's a really moderate to severe case, they may be on an immunosuppressor drug that suppresses the immune system. So it can vary. And sometimes, depending on if the case is moderate to severe, they'll be on a combination of drugs. So let's look at these categories. Okay, first category are called 5-aminosalicylates. Popular one or a common one used is sulfasalazine, and this is an anti-inflammatory medication. So what do we have going on in Crohn's? We have a lot of inflammation. So we want to decrease that inflammation, which can help that tissue heal and hopefully prevent a flare-up and maintain remission. Now, these are usually used first line for mild cases, and they can't be used in patients who are allergic to sulfa. Instead, if the medication isn't working well or they are allergic to sulfa, they may be prescribed a corticosteroid. Type could be used called prednisone. These medications are not for long term, and as we learned from our endocrine series, corticosteroids can have some really nasty side effects to them. What they do is they decrease inflammation, which is good, but the side effects that come along with it are not. And you can have increased blood sugars. I've had patients who their blood sugars will be through the roof, like 400, 500, 600, and they're not even diabetic, but it's from these corticosteroids. So we have to start giving them insulin, help getting it down. So this is common. So if you have a patient on corticosteroids, make sure you're watching for those classic signs and symptoms of hyperglycemia, like the blurred vision, excessive thirst, the polyuria, things like that. And it increases their risk to fight infection, getting infection, osteoporosis, wearing those bones thin, and thinning of the skin. Other ones prescribed, and these are for severe to moderate cases, if they're not responding to any of these other medications, are the immunosuppressors or modulators. And these may be used if the patient needs to come off steroids because they have all these side effects or in conjunction with steroids. And first group are the suppressors, which, just like its name says, is it suppresses the immune system. One used is called azathioprine, also called Imuram, and this decreases the immune response. However, the patient is at risk for infection because we told the immune system to back off. So now invaders can come in and cause infection. Also cancer, and no live vaccines with that. So if a physician or someone comes along that really doesn't know the patient, orders a live vaccine, that should throw off a red flag. Can't give it to them because they're on a suppressor drug. Other types of immunosuppressors, they work on a biological level, so they're biological type. Popular ones are infliximab, also called Remicade, or adalimumab, also called Humira. And these are what are called TNF blockers, which blocks tumor necrosis factor, which is a protein that plays a role in inflammation. So it alters that. Now, with this drug, usually the physician will make sure the patient hasn't been exposed to TB, tuberculosis, or has an active infection of tuberculosis, so they may get checked for that because it increases the risk of developing it and can reactivate a latent infection. Increases the risk of rare cancers, and again, no live vaccines. Other drugs that may be prescribed in Crohn's that you may see as the nurse, they may be on antibiotics like Cipro, maybe treatment for an infection, or they've developed infection from all the inflammation going on, anti-diarrhea medications, or pain medications to help with abdominal pain. However, as a nurse, you want to remember no NSAIDs with this condition because NSAIDs cause a lot of damage to the GI lining, and we already have damage to the GI lining, so we don't want to give them NSAIDs to make it worse. Okay, so that wraps up this lecture on Crohn's disease. Thank you so much for watching. Don't forget to take the free quiz and to subscribe to our channel for more videos.